Moving on, so I'd like to introduce Edwina Brown, who is Professor of Nephrology at Imperial College London, and she's going to tell us about assisted PD current practice and can we enable universal access.
Okay, so you've all been listening for far too long, so I'm going to ask you some questions before I start on the talk. How many centres here are not doing assisted PD? Okay, so there's one centre, so that means most of you are doing assisted PD, or you don't want to raise your hand. And how many places are struggling with getting technicians or assistants? Okay, so this is what's going to, I think it's going to be the nuts and bolts of this talk. So first of all, I want to thank Uday for asking me to do this talk, because it's actually stimulated some interesting data. So assisted PD, we tend to think about it just for older, frail people, but actually it's for both incident and prevalent patients, and it's not just for the old and frail. It's also for people with learning disabilities, mental health issues, acute start, and it's really important for keeping people on home-based treatment when something awful happens in their life, like their spouse dies or they've had a stroke, and they can no longer do their PD. And we need to remember what assistance is actually for. I mean, we talk about assisted PD with a sort of as a blanket term, but actually there's many different parts of the PD process that may need assistance. So, you know, some people may just need assistance with exit site dressings or they may need it, you know, just to have, I mean, we've got a lady who's got a bad back and she just needs assistance to lift the bag up. So it does vary from person to person. And there are also different ways of delivering assisted PD. So this is a table that I put together for a European work group that we were looking at, which Baxter funded, to look at the use of assisted PD across Europe. And I mean, assisted PD started in France with private community nurses, and is still done in France with private community nurses who get paid per exchange. So as you can imagine, it's really lucrative for them. So they rather like doing it. In other parts of the world, they're using non-healthcare professionals like we do. British Columbia in Canada is the biggest use of that. And in China, I really like the idea of using younger PD patients. And this gives them employment, because they may find it difficult to get jobs, and yet they're getting some payment for going around helping older people to do their PD. What isn't in this table is the use of domestic workers. So in Hong Kong, which is PD first, and they go around telling you how much everybody gets put on PD, actually it's mostly done by domestic workers. So it's clearly still being done at home, and it has lots of healthcare benefits, but people can stay in hospital for weeks waiting for the family to find a suitable domestic worker. This is French data looking at people really staying on assisted PD until they die, and showing that there's a much lower rate of transfer to hemodialysis for people. These are obviously all older, frail people, and they stay on hemodialysis and stay on PD. They don't transfer to hemo, and they actually die on PD. Fairly old data, but this is much more recent data showing exactly the same thing. In the first 6 months, there's no difference in terms of transfer to hemo or death, because really that's just a sick group of patients. But after that, people who are on assistance have much longer survival on PD compared to self-care patients. And this slide is from the British Columbia experience, which I think is very pertinent to us here in the UK, because they've actually used our model of assisted PD, which is using non-healthcare workers to do 1 visit a day for APD, which is what we started off as in this country. And this is a look back over 5 years of it. And as you can see in the bottom graph, how the program has grown over 5 years. The bottom graph, the survival data showed that people on assistance stayed longer on PD than those on self-care. But really the most important, I think, in terms of managers, unfortunately, is the costs. And what that shows, it's the assisted PD on the left-hand bar. So the dark blue is the cost, and the red is the extra cost you've paid for the assistance. If they weren't on assisted PD, they would have gone into extended living facilities. So that the middle bar shows you what it would have cost if they'd gone into extended living, where the assistance would have been provided by the staff in the extended living facility. And that's obviously much more expensive than PD at home. And then the last one is the cost of in-center hemodialysis, which is even more, and that includes, I think they included the transport costs. So one of the problems in this country is that hemodialysis costs doesn't incorporate transport. And if you incorporate transport, it all looks very different. So last year, the ISPD published a position statement on assisted PD. I'm not going to go through it in detail, but what it concluded was that assisted PD increases equity and access to home dialysis. It's associated with increased PD incidence and reduced transfer to hemodialysis, and that government and private insurers should fund assisted PD to ensure sustainable support. And we need to remember, however much we moan or think we've got problems with assisted PD in this country, we've at least got it. So this is a graphic that was actually based on the data that we put together for the NDT paper, showing that in Western Europe, there is only out of the 13 countries that were taking part in the group, only 5 had assisted PD available. So the England, so the UK, France, Denmark, Belgium. I can't remember what country that was. Right, and all of Sweden and Denmark, Sweden, and Norway. So what happens in the UK? So I did a survey back in 2009, and then when Uday asked me to talk and tell you all what happens in the UK now, I said I couldn't possibly give a talk about what happens now, because this is unfortunately not data that's collected by the renal registry, and we would need to do another survey. So let me just show you very briefly what happened in 2009. So that we started the first pilot of assisted PD with Baxter in 2005 at the Hammersmith and Charing Cross. And then that morphed into the West London Renal Centre during the project. And then it started being taken up by some other units and eventually got onto a tariff. So we did this survey. I sent it out to PD units that were enrolled because in what was then the EPS registry, because it was also the time when EPS was rife in this country, unfortunately. And so we had this registry and members. And I also sent it out to people nephrologists that I just took at random from the Renal Association list of members who I knew were not PD-based nephrologists. And at that point, there were 142 patients on assisted APD. At that point, about 40% of people were getting their healthcare assistance from Baxter, through a healthcare agency. Otherwise, they were using different things, district nurses. A couple of places were employing their own assistants, etc. We asked people about various attitudes, and the one I've put in red in this slide was frail patients are best dialyzed using hospital hemodialysis, which unfortunately still happens. And as you can see, the PD people completely disagreed with this statement, 90%, and even 2/3 of the non-PD nephrologists disagreed with that statement. And then sort of overview of the comments, people were enthusiastic that they wanted it to be available for more patients, but the concerns was that there was no tariff. I think that came in a year or two later. There were problems with getting assistance, and the model at that point was limited to 1 visit a day, which did limit the people who could use assisted PD, because if you couldn't do your own connection and disconnection, then it meant you couldn't be on assistance. So we repeated the survey this year. So many thanks to Mark and Uday, who helped me put this survey together. And I think most of you in this room would have had the letter that came with the survey or the email asking you to complete it. So we had responses from 47 centres. So that was the majority of centres in England, 38 out of 49, about half in Scotland, half in Wales, and 1 out of 5 in Northern Ireland. Mostly, not surprisingly, it was completed by nurses, and only 3 centres who responded reported that they didn't have an assisted PD programme. And overall, it was roughly about 12.5% of people on PD in the country were on assisted PD, but there was huge variation. And many thanks to the Renal Registry for putting all this data together for me. So this is the funnel plot showing centre variation, percentage of PD patients receiving assistance. And as you can see, that there's huge variation across the country. How's it being delivered? Well, by an independent industry provider in 54% of centres, and that's predominantly Vantive. About 1/3 of centres are employing their own assistants, and then there's about 14%, 6 centres, who had a mixed economy of their own assistants or using industry support. Interestingly, the proportion of PD patients on assisted PD, when you looked at the proportion compared to the prevalent PD population, was higher in centres employing their own assistants. So that was about 14% compared to industry provided only, where it was only 8%. And the way the assistance was being offered was again varied. So about half of the units still just offering 1 APD visit a day. 20% were offering APD with 1 or 2 visits a day, and about 1/3 were using a combination of CAPD and APD visits. We at Imperial predominantly start people with on assisted CAPD, 2 exchanges, and would move people onto APD. And this just shows it all in a bar graph form. This is a map showing responses across the UK. So the bigger the bubble, the more people that have been on it. And as you can see, it's widely distributed across the country, where people, how much assisted PD is being offered, and the Red Crosses are centres which didn't send any. So we rather lack information for sort of east of England, North Midlands, or the north of Manchester, etc. There seemed to be no correlation between the proportion on assisted PD and the size of your total dialysis of PD programme, though we need to look at this in slightly more detail. People were asked for comments, and there was a quantitative analysis. So blue is strongly agree, so it's strongly agree at the left-hand side, and then moves to disagree on the other side. So purple is strongly disagree. So assisted PDs limited by availability of assistance, that seems to be a big issue. So about 2/3 of centres almost said that assisted PDs limited by, agreed with that statement. Assisted PDs limited by lack of familiarity among staff, that didn't seem to be a big issue. Limited by local funding, that was true in about 1/3 of units. Limited by location, again about 1/3 of units, and should be the main dialysis modality for older people, and that was about 60% of people. People were asked, there was some free text, about 1/3 of respondents reported no barriers to assisted PD in their centre. The comments that were most frequent were about availability of healthcare assistance, geographical challenges, etc., and that was equal amongst however it was being provided, whether it was through you organising your own assistance or getting them from industry support. Most centres, well, 30 centres said that they had no patients who could not start PD or transferred out because of lack of healthcare assistance, but 11 centres had patients unable to either start or continue PD because of lack of assistance. And if you looked at centres with perceived barriers, about 11.5% use of assisted PD for their PD population, compared to 13.7% in centres with no barriers. And that's probably not statistically different. So this is the first study really to look at assisted PD practice in the UK for a long time. It shows significant unwanted variation in the proportion of patients using assisted PD. It was not associated with total PD prevalence in the centre, suggesting that there's lots of other factors, both patient and centre-related factors that influence PD usage. And we really need a national strategy that includes how do you train staff, how do you put this into renal service specifications, what are the financial incentives required to overcome these challenges and reduce the inequitable access. And I'd like to thank all of those who helped put this survey together, because otherwise, without that help, you wouldn't have this data today. Thank you.
Any questions for Edwina Brown?
In terms of working hand in hand, yeah, obviously, assisted PD primary providers often done by one party. I've noticed there's two of us really very smart in terms of engaging the industry and moving forward to make sure that some of those pockets, areas within the UK that this has been an issue. How do you work on that? I mean, what do you think next steps will be to engage? I mean, you've done a lot of work doing this in terms of interesting families, servicing back in digital SSP and the advanced these days. What do you think we should be doing actually from the DAYLife answers perspective to move this forward?
Well, first of all, I'd like to say that this model of doing assisted PD with industry support is unique to the UK. It doesn't happen anywhere else that I've visited or heard reports from. And you know, the reason that I went with it was because I feel that this is something that should be done with community support. And when I set up the first project, as it were, and that's how the whole thing with Baxter, now Vantive, evolved, was that we were unable to use district nurses, and the concept of primary care or community care buying into this just, the whole thing would never have happened. Let's face it, I wouldn't have been able to start this sort of project now in 2025. I did this with no business case, no SOPs, absolutely nothing. I just went ahead and did it. And Richard wasn't there to tell me off, to tell me that I couldn't do this sort of thing. So that's the history of it. And I think it's now a mature treatment. I think the data is there that people live well on assisted PD, that in terms of our older, frail population, this is the optimal way of looking after older people requiring dialysis or choosing dialysis. And I see a lot of people nodding their heads, so you're in agreement with this statement. I think we are now at the point where we should be sitting down with people who provide care for older people in the community and think about how do we build support for PD for these people so that we can stop putting people into ambulances and transporting them at huge expense 3 times a week into a centre where they're put on a hemodialysis machine, given acute brain injury and a further decline in their cognitive function.
So yeah, okay, Edwina, wonderful talk. I was last interested to be talking about assisted PD and how successful it's been in the last 20 years or 15 anyway since you initiated the programme, which is really wonderful. Well done to you and to everybody else who participates in it. But I thought to myself, this is really successful because it's funded. And a lot of our QI initiatives will help you to do things without any specific funding attached. Now, I couldn't help asking myself whether if there was specific funding attached to some of the initiatives that we've been talking about, whether they would happen more effectively. You see what I mean? I don't know what you think about that.
I'm not going to answer funding questions because it's really outside my my experience, but I agree. I mean, we were really lucky with the assisted PD programme because it was when Richard Fluck was in charge, as it were, and he really pushed for it to get onto the national tariff. And if that hadn't happened, as you said, the assisted PD programme would never have happened. But people were starting to do it. I mean, when I did that first survey, so you could see 36 units were actually using assisted PD. So people were doing it and funding it themselves. But there was a big enough movement for it to get onto the national tariff.
I think just a quick point as well, that there is assisted PD in the Eastern network, and just to reassure you, we did try and do a bit of work where we try and bring it in-house, because assisted PD service has a big cost to the service. I don't know if people are aware of this. So actually, if you have services that are already doing it, it would be good to link up nationally, because when we tried to do it 3 years ago, it was all very secretive and we couldn't have open discussions about it. And then when you try and set the service up, you worry about things like insurance, cover, sending people out in cars, how are they going to provide it?
But that's why we as renal units are not experts at providing community care. That's why we need to interact and not live in a little renal bubble. Because the other thing is, if you look at it from the older person's viewpoint, they've got somebody coming in to do their PD. They've got somebody else coming in to give them a shower. They've got somebody else coming in to dress their legs. Why can't we train the one person who's going to go and assist, or, you know, so they can do multiple tasks, so etc. So I think we really need to think broader about how we are going to support the increasing number of older people living in the community at a time when there's a declining birth rate and declining number of younger people who's there to support them. It's going to be a big problem, and I'm going to be one of the people, hopefully not an assisted PD.
Thanks again, Edwina. So